So good evening, everyone. My name is Dr. Rishi. I take this opportunity on behalf of Vocard Pharmaceuticals to welcome all of you to this very interesting discussion on multidisciplinary approach for diabetes care. As we all know, diabetes is a complex disorder, and the complications can affect various organ systems. And that's why there is an uh, approach which is required to manage the patient from all aspects. And that's a role for multiple specialties, including neurologist, nephrologist, diabetic foot specialist, as well as cardiologist. And the primary specialty remains the endocrinologist. So we are really pleased to have this August panel today to have this discussion. But before we get into that, I will like to welcome our president, Dr. Vijesh Gupta. Dr. Gupta is our president for sales and marketing at India business as well as the rest of the world markets. He's an alumni of All India Institute of Medical Sciences. He's a MD pharmacologist, and then he has changed his tracks to deal into sales and marketing operations. He has worked in various organizations like Rinbaxi, Zydus, Intas in his previous assignment, and comes with a very dedicated experience in both medical as well as sales and marketing. So with this, I will request Dr. Gupta to please welcome all the panelists, moderators, faculties, as well as the audience to this meeting for today. To you, Dr. Gupta.
Thank you, Dr. Rishi Jain, and good evening, everybody. Indeed, it is a pleasure to be here with you, your august presence, both of our elite faculty as well as all the delegates from across the country. On behalf of Vocard Pharmaceuticals and Vocard Medical Connect, I welcome all of you in today's Diabetes Crosstalk meeting. My name is Dr. Vijesh Gupta. I am currently designated as president and for India and rest of the world business for Vocard Pharmaceuticals. We are based out of Mumbai. Vocard has been a pioneer in diabetes management and is a strongly backward integrated organization for both research as well as manufacturing of insulins and OADs. Our facilities with world-class state-of-the-art research and development are based out of Aurangabad at Biotech Park, from where we manufacture the global requirements of insulins as well as the oral anti-diabetic drugs. Since last 30 years, Vocard has been a global leader in diabetes care and has continuously organized unique scientific activities for ensuring better diabetes care. These innovative scientific activities blended with comprehensive Vocard's anti-diabetic portfolio, which includes insulin, analogs, and we are also very strongly entrenched in diagnostics. We have got glucometers, plus the oral anti-hypoglycemic agents. Now, all these therapeutics not only keep our practitioners updated, but also enable every practitioner to take evidence-based decision in their clinical practice and achieve the desired clinical outcome for the patients, which is so much required in today's scenario. We all know that individuals with type 2 diabetes mellitus have, it's not only a diabetes is a single disease, but it is complicated with multiple complications which span across cardiovascular disease, microvascular complications, afflicting kidney, retina, and central nervous system. I believe that nobody dies of diabetes, but the chances of increased morbidity and mortality is very high on account of its complication. And hence, if you look at the overall management strategies which are adopted globally, type 2 diabetes mellitus treatment landscape has evolved significantly over the last 40 years. The clinical endpoints that the physicians use to determine the optimal care of these patients have gradually and firmly changed from glycemic control, a mere glycemic control, to a focus on prevention of comorbidities like macrovascular diseases, prevention of cerebrovascular complications, renal complications, and especially, from chronic diabetes, the complications like diabetic foot ulcer. We believe that instituting collaborative working relationship among the multiple medical disciplines is the need of the hour. And this is the reason that we have gathered here today. I'm sure that today's diabetes crosstalk on multidisciplinary approach will give a holistic perspective of diabetes management to each and everyone who is part of this telecast. And I'm sure that with your knowledge, you'll propagate it down the line. And this is exactly what is the endeavor of we sitting here at WOCAD. I'm very honored to have, stalwarts with us. It's a privilege to have Dr. Prasanna Kumar, who is today's moderator for the Diabetes Crosstalk. Welcome, Dr. Prasanna Kumar. We are also honored to have Dr. J C Mohan, who was, who's globally as well as well-renowned cardiologist with excellent insight into the diseases, Dr. J C Mohan. And we have Dr. Alan Almeida, who will enrich us with his deeper knowledge of nephrology, diabetes related to nephrology and its complications. We have a very dashing Dr. Sumit Singh with us, who will put forward his neurological perspectives which are involved in this disorder. And we have Dr. Tushar Rege to put in his insights on diabetic foot ulcers. I warmly welcome all of you, and I also warmly welcome all our delegates from across the country. And I believe that today's webinar will be indeed a highly enriching experience for all of us. Thank you very much. Over to you, Rishi.
Thank you, sir. Now I'll request Dr. Prasanna Kumar sir to take the proceedings forward to dwell into a very, very interesting topics: diabetes and comorbidities, need for a collaborative framework. Over to you, Dr. Prasanna Kumar sir.
Thank you, Dr. Vijay Gupta, for the introduction, and thank you, Dr. Rishi Jain, for this opportunity. Good evening, everybody, and welcome for this crosstalk. Why did they have this multidisciplinary approach to diabetes care? Diabetes is not just a disease of the metabolism. Previously, they said diabetes is a metabolic disease because of diabetes and protein, glucose, carbohydrate, and the fat metabolism. Then they said, no, it's a vascular disease. Most of it starts even before that. Now they say it's a liver disease. You can say it's a kidney disease. You can say everything because it's an anti-inflammatory one. You see, inflammatory disease. So every part of the body is responsible. Now you say 8 or 12 factors, 12 organs contributing, including muscles. And most of these organs are in turn affected by it. If you see how diabetes, let us say in 2017-18 was involving about 70 million population in India. By 2040, we will have probably double 137 million population in this. And in the developing country like ours, it is increasing by 74%, whereas developed countries, it is increasing by 20%. We are not just glucose-centric. Previously, we said, have a drug which reduces blood sugar, that is sufficient. Last 10 years, it has gone into pleomorphic benefits as such. It is not enough just if we just control diabetes, we should also see the complication do not occur. So to prevent this complication, what are those? Most important, cardiology, because 20 to 30% of diabetics have a high cardiovascular risk. Atherosclerosis vascular disease itself is quite common in diabetes. Maybe 30-40% of the patients our cardiology are diabetic. And mortality is also high because of diabetes as such, or the cardiovascular disease as such. So that is why we have this cross connect, where we have a neurologist. All these are neurologists, Dr. Mohan. Then you have got the nephrologist. Then you have got the neurologist and the foot surgeon. They are all experienced, 3 or 4 decades, competent, qualified, experts in their group. So this crosstalk is to see how a physician, when you treat diabetes, you should also assess the cardiovascular state. You should also assess the renal status. You should also see the foot examination is done. You should also see neurological examination. So a comprehensive care is not just glucose-centric. It should be a totality of the person, the annual checkup, so that early intervention and treatment is going to prevent complication. Definitely, we know all these things are preventable. You know that 16% decrease in the cardiovascular risk when you reduce HbA1c by 1%. So also 1% increases the 16% of the myocardial infarction and others. And if you look at myocardial infarction, diabetes only did 16%, but you should also look at hypertension, smoking, lack of exercise, obesity, dyslipidemia. So how to have this comprehensive approach, all our cardiologists, neurologists, nephrologists are going to see. Most important, we are going to discuss that when to refer. The physician holding on to the patient till the end, no. When he should refer to cardiologist, intervention cardiologist. When he should refer this patient to neurologist. When should the physician send the patient to nephrologist? Not at when creatinine is 6.5, he is for dialysis. No. Nephrologist would like to see much earlier than that. Whether regular annual checkup of cardiology is necessary. If so, what are the tests to be done? How early we can pick up the nephrological or the nephropathy assay? As we know, the diabetes complications are micro and macrovascular complications. Microvascular complications are directly due to the hyperglycemic effect. Whether you have looked at DCCT trial or you look at EDIC trial, that is epidemiology of diabetes, intervention and complication studies, which showed that a good or a tight control of diabetes can reduce nearly 50-55% of the cardiovascular mortality in type 1. And nearly 47% of all-cause mortality or even stroke and such things. So how is it that this glycemia is related to complication? What is the primary prevention? Secondary prevention. Cardiologists will tell us whether clopidogrel is better or aspirin is better. How to treat these patients when they develop early the CVA, cardiovascular strokes as such. Whether ischemic strokes are more common or whether it is a hemorrhagic strokes. So what are the peculiarities of diabetes involving heart? Our cardiologist will say. What are the peculiarities of diabetes involving the cerebrovascular, peripheral and cerebrovascular strokes as such? And what are the peculiarities of diabetes affecting nephropathy? This is what I will say. So also in type 2 diabetics, that the other studies, UKPDS and all, have shown how reducing the blood sugar, achieving euglycemia, maintaining that is also going to prevent macrovascular complication. And as I said, diabetes is only 10-15%. You should also look at other things, whether he exercises, stops smoking, and hypertension well controlled. Our cardiologist will tell us what is the goal. The recent guidelines, what do they say? Whether 100 is enough, LDL, or should bring below 70, or everybody above a certain age should be treated with statin. This is what we are going to discuss. The crosstalk is mainly involving multi-speciality. And our food specialist, Dr. Tushar Rege, has a wide experience how there is a team approach. He's not only, he has got a vascular surgeon, he has a plastic surgeon, he has got a podiatrist, and how the surgeon is involved in diabetic foot, how to treat this diabetic foot, how early you should intervene, which patient should be referred to the foot surgeon, and what are the cases you see. As we have seen, stroke has come down tremendously in the last 2 decades, but it may increase because the huge number itself will contribute to number. I remember 35 years back when I started endocrinology in Bangalore, 9 out of 10 beds were diabetic foot. Last 10 years, I have not seen a single patient with gangrene, not a single patient amputation. That shows the education, the preventive care, like Dr. Tushar Rege is doing and his team. So early detection, whether we should be having ankle brachial index, basic sector sensitivity, and how the education of the foot care. This is how I think 20 years tremendously the foot care has changed. And it is not that every MBBS, every MD can take care of the foot. You need specialists that. So you need a diabetic foot specialist. So all these experts are going to tell us how we should do, what should be blood control, and how early you should do microalbuminuria. We know that nephropathy is a big burden in India, and Indian patients are different. In cardiovascular, we get diabetes 1 decade earlier. We get heart attack 1 or 2 decades earlier. We get nephropathy earlier. Dr. Mani 30 years back has done a study in rural area, 10 to 20,000. A lot of them has creatinine higher. The GFR was lower. Why? They didn't have any symptom. They didn't have diabetes, hypertension. And is it because of our diet or genetics? We are doing some of these slides, single nucleotide polymorphism. We said we have identified some families where irrespective of the control, they get nephropathy. We have also published that. So is it that everything, the complications of diabetes are related to metabolic one or hyperglycemia, or there is genetic? Maybe 50% genetic, 50% maybe, which is non-modifiable, but 50% is metabolic. At least we can control hypertension, lipids, and diabetes. These are the things which we are going to discuss in the next 30 minutes. Please, all of you, our audience, if you have any questions, you see there is a chat box. Please put your question. You can even write, this question is for Dr. Mohan, cardiologist, or this is a question I want Dr. Almeida to answer. This is a question for the neurologist I want Sumit Singh to answer, or this is a food question I want. You can put the name or the specialty and the question. Please enter the specialist. We have got consultant whom you want to answer from. And also please put your name as well as the city, so that when we answer, so we know we are addressing Dr. So-and-so from Lucknow or whatever it is. And this is the question and the answer. So I request you, please go through this and put your question there. All your questions will be answered. We have enough of time. Now I'd like to invite Dr. J C Mohan, Chairman of Institute of Heart and Vascular Disorders, Jaipur, Golden Hospital, to tell us about diabetes and heart. What are the unique things about heart involvement in diabetes? Over to Dr. Mohan.
Thank you, Dr. Prasanna Kumar. Good evening, ladies and gentlemen, and also a warm welcome to our co-panelists. As Dr. Prasanna Kumar has rightly said that currently, if you go by the IDF data, there are 73 million diabetics in this country. 70% of them are likely to die of cardiovascular disease. I have been practicing cardiology for the last 40 years. 40 years back, when I was in All India Institute of Medical Sciences, we published some data suggesting that people with coronary artery disease, 20% of these were diabetics. We saw just some publications in which I was also involved last few months. So patients with heart failure, 50 to 61% patients of heart failure in this country studied in 3 big registries have diabetes. Remember, now the words 50 to 61%. We also looked at, recently there has been a registry called E-Ultimaster, where India was a big participant. 51% of all patients with coronary artery disease who underwent angioplasty, whether during acute or chronic phase, had diabetes. So one thing is certain, that we cardiologists, every second patient which a cardiologist is seeing now has diabetes. And this number has increased over a period of these last 40 years and is exponentially increasing. Do I have data that it is exponentially increasing? Well, somewhere in 2012, 2013, we analyzed our patient acute decompensated heart failure, and we found that 46% of them had diabetes. 3 years down the line, we did the same thing, same methodology, and found 61% of our acute decompensated heart failure had diabetes. So diabetes is involved some way in pathogenesis of atherothrombosis, as well as, of course, heart failure. Both heart failure with reduced ejection fraction as well as heart failure with preserved ejection fraction. So if diabetes, every second patient cardiologists are seeing has diabetes, these individuals need to be trained. These cardiologists need to be trained with some basic knowledge of diabetes and how to manage that. Unfortunately, cardiology curriculum nowhere includes much about management of diabetes in these individuals. Neither the professors who teach cardiology are that much aware, nor the students. My first point would be that we need to change our curriculum. At least 10% of the entire curriculum for a cardiologist during his fellowship should include diabetes, studying about diabetes. That is number one point I would certainly like to emphasize. Number 2 point, over a period of time, since cardiologists have not been involved with management of diabetes, they have not paid attention. They pass on these patients to endocrinologists or diabetologists, which is very simple. I would say, well, I would take care of your coronary arteries heart failure, but for your diabetes, you go to such and such doctor. It is easier said than done. I have charged 2,000 rupees consultation. Now Dr. Prasanna Kumar charges 2,000 consultation for something which both of us can manage at our ends separately, the patient pays double simply because I am not willing to learn how to manage diabetes, what are its issues. So that is an important issue which we need to learn. We need to have a multidisciplinary approach where other specialists need to be involved in regular care of these patients. Now, this is important. The reason is now as more and more cardiologists get involved with interventional cardiology, they lose interest in diabetes. And whenever we have now for the last, of course, 4 or 5 years, there has been a greater participation of cardiologists. I'm seeing a change, but this change is not that much as it should be. Then the next point is about the primary prevention in diabetes. Now we have said that 70% have cardiovascular disease. Fortunately, luckily, incidentally, the 3 studies which were published in New England Journal of Medicine last year put one thing was certain, that for primary prevention, aspirin has extremely limited role. The ASCENT trial, ASPRI trial, ARRIVE trial clearly showed. The second thing we learned actually from studies is that the ACE inhibitors, which we had been using for a long time. Remember the HOPE trial, and we said every diabetic needs to get ACE inhibitors. We realized the guidelines slowly changed, said that ACE inhibitors have an edge over other anti-hypertensive drugs or other cardioprotective drugs only if kidney is involved. Now that is an important issue. If in diabetes kidney is not involved, primary prevention ACE inhibitor has no additional advantage. The third point was of statins. We have learned a lot with EASD and ESC collaboration. We realize that now the guidelines mandate us to be very, very strict about LDL control in diabetes. Forget about those who have atherosclerotic cardiovascular. I am talking of primary prevention. The guidelines say if there is a person with diabetes of 20 years duration, you need to get the LDL down to below 55 milligram. A diabetic with 3 risk factors, you need to have below 55, which means you have to treat it like atherosclerotic cardiovascular disease. So this is a tremendous change. Those are gone are those days when we said the below 100 milligram LDL is good enough for diabetic individual for primary prevention. In the same way, in secondary prevention, enormous changes have taken place. And now the cardiologists are being trained and other people are also being trained and talked about that. Our first priority has to be cardioprotective drugs. And the second priority has to be cardio-safe drugs, even though they are not cardioprotective. That means they don't cause hypoglycemia, they don't cause weight gain, they don't cause heart failure. And of course, third, last is drugs which you have to compulsorily use because you're not able to control diabetes, but they still, these drugs are necessary, but they have the collateral damage of hypoglycemia, weight gain, fluid excess, and of course, fluid retention. So the 2019 guidelines for cardiologists written with the collaboration with diabetologists have taught us how to manage our patients with diabetes. Having said that, it doesn't mean that we don't require a diabetologist or endocrinologist. All I want to say is at least 70% of our patients we can manage ourselves if we have basic knowledge of diabetes and we actually talk to each other on a regular basis. 30% we definitely need, will definitely need specialists, endocrinologists, and these are complicated diabetic individuals, of course, who may have actually hypoglycemia may be a major issue. Control of diabetes itself may be a major issue. There may be need to read CGM properly. Pumps may be required, and those patients are there. But fortunately, with adequate training, right from the beginning, probably 70% of diabetes patients can be reasonably well treated by cardiologists. So finally, what do I want to say at the end? All I want to say at the end is for those who are managing the affairs of the academics and curriculum, diabetes should be a subject which should be taught to all cardiologists right from the beginning, and there should be an emphasis on that. Number 2, we need to have great collaboration. By the way, when I was talking about that thing, we realized that the 2 studies which we published in last 6-7 years, 29% to be precise, our patients have CKD stage 3 or more. These are individuals who are diabetic and who have coronary artery disease both, which means that not only we are going to be cross-talking with the diabetologists or endocrinologists, quite often we are going to be cross-talking with nephrologists. It is a good thing now that we have an axis in which cardiologists, endocrinologists, and nephrologists talk to each other on a regular basis and try to understand each other's viewpoint. Certain things I might feel should take precedence. Nephrologist thinks that should come down, and the nephrologist add something. And few of the things we all may not agree. And there comes the role of course, some kind of consensus building. Having said that, I do understand that the future belongs to crosstalk, or what we call a multidisciplinary approach as far as management of diabetes is concerned. And it's not a turf war. There is enough number of patients for everybody. There is enough number. I have no hesitation in saying that at the moment, cardiologists are seeing more diabetes patients than endocrinologists, simply because the number of endocrinologists is relatively small. But the patients are so large in number that there is no turf war. Everybody has sufficient work actually, and sufficient work to do and take care of the patient. So rather than thinking of turf war, we should be working together. Those are some of my thoughts about this crosstalk. Thank you very much, Dr. Prasanna Kumar, again for involving me in this issue.
Prasanna Kumar sir, you are on mute.
Thank you, Dr. Mohan, for an excellent initiation of cardiovascular disease in diabetes. I agree with you. You said cardiologists should know more and more of diabetes. Not only that, management. Other way also is true. Diabetologists also should know heart. They should also understand all the medication treatment, if not intervention. Non-intervention one about hypertension. You also said about the importance of 60-70% of angiograms you do, you see the diabetics are involved. 50% of the admission in the hospitals are diabetics. And you also said how ACE inhibitors, it's something like a sacrosanctum. Nobody can be there without ACE inhibitors, but the target is more important. I remember Dr. Mani, nephrologist, telling 20 years back, don't bother about ACE inhibitor or anything. 130/80 is better than 140/90. How you achieve it does not matter. And what he said 20 years back is very true today also. Now the guidelines are changing. There is no such sacrosanctum. You also said how the studies and guidelines are changing. Everybody has got the same fact, how that 10 different guidelines have different things. And that is because not more than 50% of guidelines are based on evidence A level. Most of them are level 2, level 3, some of them are level 4 also. So don't think all guidelines are sacrosanctum. What is the latest in that part of medicine is more important than anything. And you also emphasized thinking 100 LDL, they're all gone. Now, as you said, it should be less than 55 primary prevention. Don't stop at 80, 90 or less than 100. So these are some of the things. And also, a diabetes medicine is not safe enough if it brings down blood sugar, cardiovascular safe, even renal safe also. And you also said importance of nephrologist. Now we have got Dr. Alan Almeida, our nephrologist, consulting nephrologist and transplant surgeon. We would like to hear from his how the diabetes affect the kidney and what are the things that are special about diabetes kidney disease, CKD. Most of them, as you said, refer at stage 3 and stage 4 CKD. How early to detect and refer the patient to a nephrologist. Over to Dr. Alan Almeida, please.
Thank you, Dr. Prasanna. And after that very lucid talk from Dr. Mohan, who made his point about the need for a multidisciplinary approach to the management of diabetes, a diabetic patient, I would add my weight to that. In my clinic, I see increasing number of patients with diabetes. Not only in the clinic, but this is also translated into the number of patients on dialysis or needing a transplant. So the numbers are increasing. As Dr. Prasanna has already mentioned, that we are the diabetes capital of the world. And in the future, we are going to see more and more of these patients using up services which may be inadequate. So we definitely need to prevent diabetic end organ damage so that we don't have patients landing up with dialysis and transplant. The diabetic patient has multiple comorbidities. That's why we are all here on the panel picking up our area of specialty and telling us how we need to coordinate things so that we have a multidisciplinary approach to the management of the diabetic patient. But let me start right at the beginning. There's a common concept that every patient who has diabetic kidney disease. And we do see in our practice more patients with type 2 rather than type 1 diabetes. And we feel that every patient who has got diabetes has a diabetic kidney disease. I might bring it to the attention of all that around about 30% of patients in studies which have been done across the country have what we call as a non-diabetic kidney disease. So that would only be evident when we do a biopsy. Now the biopsy, a kidney biopsy, which would give us the diagnosis, is restricted to those patients who have either evidence of a failing kidney in the form of a raised creatinine, or in those who have large amounts of protein being lost in the urine. But to complicate things further, is another entity called as the non-proteinuric diabetic kidney disease. These patients do not have the protein loss in the urine which we associated with diabetic nephropathy in the past. So much so that we're now talking in terms of diabetic kidney disease, which is all-encompassing, and then we have the non-proteinuric diabetic nephropathy and the proteinuric diabetic nephropathy. The proteinuric diabetic nephropathy is those who have large volumes of protein in the urine, large quantities in excess of 300 milligram per gram of protein in nephrotic states, and the one which we recognize from the beginning. But we have to identify the non-diabetic renal disease patients who have no relationship of the kidney disease to diabetes, or the only fact that they have a diabetes in association with their kidney disease, which may result in a sufficient, if you do a biopsy, you might find patients among them who could be benefited with some form of treatment. I had a patient who was transferred to Mumbai for construction of an AV fistula. The patient had a creatinine of 10 milligrams plus, and the patient was all planned for the AV fistula. Then we said, let's look at the kidney sizes, and we saw large kidneys. We decided, let's go ahead and do a biopsy. And we did the biopsy, and lo and behold, we found that the kidney disease was not related to the diabetes, but was related to an acute interstitial nephritis related to the ingestion of a herbal medicine for arthritis. And within 24 hours of starting steroid therapy, this patient started passing urine. And the patient went home with a normal creatinine and no preparations for end-stage renal disease treatment. So that's where we need to be. We need to differentiate between non-diabetic renal disease and the two forms of diabetic kidney disease, that is the one with protein leak and those without protein leak. We also know that in the non-proteinuric diabetic kidney disease, the rate of progression is lower. They usually also have a lower blood pressures. So their decline in GFR is much lower. Now we come to the point is, when should a nephrologist get into the act? Dr. Prasanna has already mentioned that we don't need to come in late in the disease, because by that time, all our attempts to retard the progression or to control or to even reverse whatever is reversible of the diabetic damage to the kidney has already gone past. So that we need to be referred early. And the other thing is, should the nephrologist only take care of the patient when he has an established kidney disease? Again, Prasanna has rightly said that we should identify the onset of kidney disease and take corrective steps right at that stage. And there's exciting material, information now coming out in the literature that some of the medications which are used by the diabetologists to treat diabetes, I refer to the SGLT2 inhibitors, wherein there has been a recent trial which was stopped prematurely because in the DAPA-CKD trial, they found that the was beneficial effect not only in the diabetic, but even in plain patients with kidney disease. So that is what, so the right combination of medicine, this again was brought out by Dr. Mohan as well as by Prasanna, that the right combination of medicine needs to be given. We've talked about ACE inhibitors, ARBs, and the way in which they can control the diabetic damage and how they can be beneficial. Now, there can be combinations of the RAS inhibitors along with the SGLT2 inhibitors, which would also be synergistic in their protective effect on the kidney. Now, we do know that we don't win all battles. So some of the patients are going to slip through either for reasons related to the lack of approach wherein they are informed about all conditions which would worsen their kidney or they worsen their diabetic complications, or have not been exposed or do not have the expertise to have these services. Yeah, it has also been mentioned by Dr. Mohan that when you have a diabetic end organ damage, like a heart or a kidney, along with the diabetic consultation, there would be also consults with the other specialities. And if you have something like a diabetic foot or a neuropathy, then you have the other specialists on the panel also who will be involved. So what I'm getting at is that if a person has gone down the road and is now end stage and requiring a transplant, we would like to have a patient who comes for a transplant who is free from cardiac disease, free from neuropathy, and does not have an amputated limb or toes. So they have the rehabilitation process is total, not just related to the kidney. So you need to look at the various systems which can get affected by the body. Therefore, if you plan a multidisciplinary approach, you should have all these specialists on board, the educator who teaches the patient what is required and how to. You need not have a consultation every time, but the educator can definitely follow up and bring things to light. The patient who is smoking or continues to smoke would add to his peripheral vascular disease. The person, or even to his kidney disease for that matter. Or if the person has a foot injury and has lost sensation, this sometimes goes unnoticed. It's only when you ask them a question, do you have sensations on your feet? Do they say, yes, we do, we don't, or whatever it is. And we don't feel this, or he has never felt it. These are the type of things which are required to be. Also, the fact that it affects so many organs of the body, or organ systems in the body, may also lead to the psychological element. Many of them patients are depressed, and then they let things go by the way. Physical therapy, that's another area which needs to be. Then skin problems, the skin issues, the nephrological manifestations. Now, when as I see it today, I see a light on the horizon, and I anticipate that with the new therapies which come into play, that we would be looking at dealing with a diabetic patient right from the beginning, and with a recipe which would prevent him from having organ damage. I think my contribution would be to today's discussion.
Thank you, Dr. Alan Almeida. Before we let you go, and before I ask the neurologist to chip in, there are two questions I want you to take at this point, because it is good. At the same thing, you have answered some of them. There's a question from Dr. Pradeep Sanghvi. If urine routine shows traces of protein, what is the role of microalbuminuria or urinary albumin-creatinine ratio?
Okay. As you see, first of all, I would like to say that the term microalbuminuria is now been shelved, and we now talk in terms of normal or mildly elevated proteinuria. Microalbuminuria would be a moderately elevated proteinuria. That means that 30 to 300 milligrams per gram of creatinine, or UACR, urine albumin creatinine ratio. This would be an indicator, a marker. There are certain conditions which you have to have fulfilled. There should not be any fever. There should not be heavy exercise. The same conditions which we used to rule out when we are doing a sample for microalbumin excretion. The sugars should not be acutely elevated. There should not be any other condition which which would result in an increase in the albumin excretion. So this is a good way to follow the progress of the disease. Now, as I said, when we're looking to differentiate between non-diabetic renal disease and diabetic renal disease, we look at other factors, like I always say that the protein should be associated with you know what is the cause of proteinuria by the company it keeps. So if you have microscopic hematuria, if you have hypertension, or there's an increase in the creatinine, which is rapid, then you're thinking in terms of a non-diabetic renal disease. So then you would definitely go ahead with a kidney biopsy. If you get a hypocomplementemia in association with that, then you would go ahead and do a kidney biopsy. So that's as far as the role of the. And remember, trace proteinuria in a female may be due to contamination by vaginal secretions.
I have one more question, Dr. Alan. The question is from Anup Kulkarni. Sir, how can we differentiate between benign hypertrophy of the prostate, related nocturia, and diabetic patient having increased frequency of urination in the night?
Okay. See, basically, if your sugars are controlled, you have no reason to have a polyuria or nocturia. If your kidney function is normal, that means your creatinines are not high, then you would not get a nocturia. If you're non-edematous, if you've not got a cardiac issue, if you've got cardiac failure, you're going to be having peripheral edema, and that edema basically gets more remobilized into the system and then leaks out at night. So once you are in the supine position, all the fluid returns to the system and you excrete it. Now, a benign BPH, benign prostatic hypertrophy, yes, the patient could have an increased nocturnal frequency. But when you've ruled out other things, then you can, and if it's in the appropriate age group, you can think in terms of a BPH. You could also go ahead and do an ultrasound and see what is the size of the prostate.
One more thing before I let you go, before I go to Mohan for some cardiac questions. Dr. Prahalad Chawla has asked, what is the red flag for physician to refer to nephrologist?
Okay. Basically, there are two things. One is, I told you about a non-proteinuric nephropathy and a proteinuric. So if you have proteinuria, definitely nephrologist. Of course, as I said, I myself work hand in hand with the diabetologist. I don't only just treat diabetes and the kidney disease, but I work hand in hand. And we are in hospital, we have the diabetologist at our doorstep. That's one. Second thing is, I look at the creatinine. We are talking now in terms of the creatinine clearance, and we have very good equations. Of course, unfortunately, these equations have not been reconfirmed in the Indian situation, but we feel that a CKD EPI, that's a formula which is available. If you take the creatinine, you can find out at your age what would be the likely GFR from that, and that would be an indication. So you follow this, and then this is the only way you can go. You can't go doing biopsies on every patient. As of now, we don't have any other marker. Maybe in the future we could have something.
Okay. Dr. Mohan, I have two questions. Before we move to neurologist, I want you to answer. There's a question from Dr. Palnichami Tangam. He has asked, Dr. Mohan, what is your clinical experience about new fancy drug SGLT2 inhibitors?
So I think these drugs, in fact, were introduced to me first time in 2008 when some trials were being conducted, and I thought that was a funny way of treating diabetes. But since September 2015, when EMPA-REG outcome data came up, and a year later came the Canvas, and then of course the Declare in 2018, and then of course DAPA-HF Credence, one thing is certain. These agents are class 1A indication for all patients with atherosclerotic cardiovascular disease and all patients with heart failure. And I use them extensively. At least 50% of my prescriptions will carry these agents. GLP-1 analogs I'm not using that often because of the cost issue and because of nausea, vomiting 20%. And also there are some increase in heart rate and other issues which I don't want to go in. But you said about SGLT2 inhibitors, extensively I use it. I think there is a tremendous potential to use these drugs to reduce final cost to diabetic individuals in the form of preventing hospitalization for heart failure, and of course, to some extent, preventing atherothrombotic event. Much more is the fact that a good number of our patients have associated kidney disease, and this probably is the most powerful renoprotective agent we have known. Because of these multiple reasons, I am a strong advocate of using SGLT2 inhibitors in conditions where they are required. And unlike other friends who actually talk about a good number of mycotic infections, I write 5-6 prescriptions every day. I must have 7,000-8,000 patients on these drugs by now. I don't see that much of mycotic infection. You just have to educate the people. I'm quite convinced they are the most fantastic drug which have been discovered in last 1 decade.
I agree with you, Philly. There is a last question for you. Dr. Pradeep Singh has asked, I'm sure this is what in the minds of most of the physicians. In asymptomatic diabetic patient, what is the minimum cardiovascular investigation that you would like to do?
So there will be 2 blood tests which I want, that is lipid profile and biomarker, essentially NT-proBNP. I want ECG, X-ray, and echo. These are 5 things I want in asymptomatic individual. And you might ask, do we have guidelines which say I need an echocardiogram? After the famous Dutch study, cross-section study, which showed a 28% prevalence of heart failure in a structured diagnostic workup of routine diabetic volunteers, I have come to this conclusion that the 2/3 of these diabetic people actually would have some or the other abnormality, which will warrant them putting in a higher risk category by doing an echo, and hence, of course, treating them in a different way. 5 things. 2 biomarker, lipid profile, of course, which you will do in any case. Biomarker, which means NT-proBNP and troponin, of course, they come together. They are actually one and this in the same package actually, and the cost is lower than $20 US. And of course, ECG, X-ray, and echo. Nothing beyond that. I am not in favor of fancy stress echoes, ankle brachial index, carotid intimal thickness, CT cornea angiogram. Those are absolute no-no for asymptomatic people. That is absolutely not indicated.
Thank you, Dr. Mohan, for clarifying all that. Now we move on to the neurologist. We have Dr. Sumit Singh. He is the Director of Neurology, Agrim Institute of Neurosciences. We would like to hear from him. What about the central nervous system, peripheral nervous system involvement in diabetes? How does the cerebrovascular accidents in diabetic differ from the non-diabetics, and when they should refer to the patient to the neurologist? What are the things to look for our early involvement? Over to Dr. Sumit Singh.
Okay, I would be using my slides. So may I request to allow me to do that?
So please, you can share.
Is it visible?
No, not yet, sir.
Now?
Not yet.
Is it visible now?
No, it's coming, sir. Yeah, it's visible, sir.
Okay. So as it has been pointed out rightly, the neurological complications of diabetes are a spectrum of the various other disorders which are there in diabetes, which affect the other systems of the body. Now, there would be several aspects to the neurological complications. Some of them would be direct implications of long-standing hyperglycemia and diabetes. The others would be indirect complications of diabetes, which affect other systems and then affect the brain. So the direct complications are neuropathy, the radiculopathy, and the myopathy. And then indirect complications are that because of enhanced atherosclerotic complications, which result into stroke. And it is the same complication which also increases the risk of cardiovascular complications in diabetic patients. Then you have neuroinfections, which is a reflection of altered immune status of these patients. Then a worsening of the previously existing neurological complications or problems due to diabetes, and then dementia. So diabetes is an independent risk factors for every single aspects of these indirect complications. Stroke is an indirect complication of diabetes. We know that patients with diabetes would usually also have a poor lifestyle, would also usually have a impaired cholesterol metabolism. They would have a very altered type of lipid profile. They would have enhanced atherosclerosis because the intrinsic pathophysiology of atherosclerosis is worsened by diabetes, and therefore the presence of advanced atherosclerosis causes increased risk of stroke in these patients. The immunity aspect, we all know that there is impaired immunity in uncontrolled diabetes, so they are more likely to develop central nervous system infections, particularly fungal infections like mucormycosis, like cryptococcosis, like aspergillosis, and infective conditions of the skull and the paranasal sinuses. Dementia, diabetes is an independent risk factors for both minimal cognitive impairment as well as for dementia. Then we look at the neuropathy, and now neuropathy could be of two types. One is a symmetrical neuropathy and the second is an asymmetrical neuropathy. The symmetrical neuropathy is sensory or sensory motor. It could be autonomic, it could be symmetrical proximal lower limb motor neuropathy, and then there would be mixed forms like diabetic neuropathic cachexia and polyradicular neuropathy. The asymmetrical neuropathies involve the cranial nerves. There could be a truncal involvement, particularly the dorsal neuropathies. Then there could be a limb plexus involvement, mononeuritis multiplex, and entrapment neuropathies apart from the ischemic neuropathies. Now, it is important to understand that the most common neuropathy which one sees is a diabetes sensory or a sensory motor neuropathy. And this sensory neuropathy could be of two types. It could be painful or it could be non-painful. Now, painful diabetic neuropathy is the second commonest neuropathy, and the commonest one is a diabetic sensory neuropathy. Now, we all know that many patients have the diabetic sensory neuropathy, in which they would have an impaired sensation in a glove and stocking distribution. And many times we observe that these patients have been prescribed these pain modifying drugs like pregabalin and gabapentin, because these drugs have zero role in the pathophysiology of diabetic neuropathy. They have zero role in improving the sensory component of diabetic neuropathy, and their only role is in the treatment of the diabetic neuropathic pain. But unfortunately, it's written left, right, and center as pregabalin being the first choice, as if it's a panacea for treatment for all aspects of diabetic neuropathy. Autonomic neuropathy can present as erectile dysfunction, it can present as gastroparesis, it can present as alternating diarrhea and constipation. It can present as increased frequency of urination, both in females as in males. It can cause dyspareunia in females and males. It can cause vaginismus in females. Then the symmetrical proximal lower limb motor neuropathy is an unusual neuropathy, but most of these patients who have diabetic neuropathy, even if it is extremely severe, then also it will never be severe enough to impair a patient in his activities of daily living. So if you actually see a patient who is on a wheelchair because of nerve involvement, it is unlikely to be diabetic neuropathy, and most likely it is going to be a CIDP or a chronic inflammatory demyelinating polyneuropathy like presentation of diabetic neuropathy. Many times these patients present with severe lancinating pain in their dorsal distribution, and this is because of involvement of the intercostal nerves and the radicals in the intercostal nerves distribution, which cause painful lancinating pains in the intercostal spaces. And similar pains can also be asymmetrical in the lower limbs, which presents usually as asymmetrical quadriceps myopathy or asymmetrical diabetic femoral neuropathy, which is usually seen when the patient is getting seroconverted from a non-diabetic status to a diabetic status in early diabetics as an asymmetrical, severely painful involvement of the quadriceps muscle and the femoral nerve. And these patients usually present with pain and wasting of the quadriceps muscle apart from a sensory impairment in these areas. Carpal tunnel syndrome and other entrapment neuropathies are also more common in diabetic patients. And because of diabetic microangiopathy, ischemic neuropathy or ischemia of the large nerves can also be seen in diabetics. Now, why this happens, it's difficult to know. And there are several types of theories which have been put forth. And I think that whenever you have more than one theories in the causation of a disorder, probably none of them is correct. So microangiopathy, aldose reductase pathways dysfunction, advanced glycation product assimilation, oxidative stress, hyperglycemia per se, and activation of the glycol pathway are the ones which are the proposed mechanisms for diabetic neuropathies. Now, the treatment component is difficult because there is actually no cure for diabetic neuropathy, and the best way is to prevention. And multiple trials have shown that the single most important component is the blood sugar control. It should never be overcorrected because hypoglycemia in itself can trigger off hypoglycemic neuropathies, but adequate control of sugar is extremely important. But even if there is adequate control, then over a very long period of time, diabetics would develop some degree of sensory neuropathy, even if their blood sugar control is extremely good. So no doubt that a very good control of sugar is going to prevent the worsening of diabetic neuropathy. But it is not that you will never develop diabetic neuropathy if your blood sugar control has been good. If there is a significant amount of pain, then apart from blood sugar control, the management of diabetic neuropathic pain, which in itself is a full discussion point and a full CME, is advised. And there are various drugs which are available like pregabalin, gabapentin, amitriptyline, duloxetine, oxcarbazepine, carbamazepine, and others. So these are the ones which one can advise for management of the diabetic neuropathic pain. And apart from that, some patients who develop impairment in their activities of daily living, like a CIDP-like presentation of diabetic neuropathy, we can offer these patients as IV immunoglobulin or plasma exchange. Sometimes the steroids might be required, and steroids, of course, whenever are given to a diabetic patient would cause a worsening of the diabetic control, and therefore it has to be a multidisciplinary approach in such conditions, because many of these patients who develop neuropathy already have a coexisting cardiac problem. They also have a coexisting nephro problem, and therefore their blood sugar control becomes a real big problem for the neurologists whenever these patients are on steroids for CIDP-like manifestation of diabetes. Therefore, as it has been highlighted right from the beginning, there is no other discipline in the entire medicine where a multidisciplinary approach carries more importance than it does in diabetic patients. Thank you very much for your kind attention.
Thank you, Dr. Sumit Singh, for a very comprehensive coverage of neuropathy. You have spoken about the peripheral neuropathy, different classification. One question I would like to ask. I know there is nothing like primary prevention of cerebrovascular accident, but for secondary prevention, what is the drug that you choose, and are the guidelines, and how long it is going to be used? Because a lot of people use aspirin, some of them prefer high dose, small dose, or clopidogrel. What does the evidence and guidelines say, and how long you can use for secondary prevention?
Okay, so secondary prevention of stroke, the guidelines currently are that after an acute event, the patient has to be put on double antiplatelets for 3 weeks, and then you switch over to single antiplatelets. The drug of choice would still be aspirin unless and until there is either a risk of bleeding, there is an allergy, or there is an associated cardiac problem for which a stent has been put, in which case a double antiplatelet has to be continued for a long time, and probably clopidogrel might be a better option. So for 3 weeks, the recommendations are for double antiplatelets after an acute stroke, and then we switch over to a single antiplatelet.
How long you will use that?
Single antiplatelet has to be given lifelong, sir, after an acute event.
And what about elderly people? Let us say 65, 70, 75. First time is
All-
a double-edged sword. How do you consider using a diabetic these antiplatelet drugs?
All ages, one has to have a lifelong prophylaxis with the antiplatelets. If the patients are old, more than 70 years of age, the dose might be a little lower. We might continue with 75 milligrams of Ecosprin, but we definitely have to give it lifelong.
Okay, there is one question from Dr. Vinod Kumar. Role of aldose reductase inhibitors in peripheral neuropathy, your experience.
It is a very well advised placebo. It is an expensive placebo. People feel very good when you give them that at least you are giving something to prevent. But there are no proven studies which have shown that they cause prevention of development of diabetic neuropathy or have major change in the clinical course of diabetic neuropathy.
Okay, there is one last question for you before we move on to the foot surgeon. Dr. Padnichami Tangamanas, Dr. Sumit, how do you manage the negative symptoms of DPN? This is what most of them have numbness and no positive symptom. How do you manage them?
There is practically nothing which helps, and one has to actually counsel these patients that we can give you whatever you want to, but unfortunately nothing is going to work. So we usually tell them to have a diabetic foot care in terms of taking care of injuries to prevent them from getting microvascular problems to developing sores. That is what we advise these patients. But what we don't advise is the pain modifiers like pregabalin or gabapentin.
Thank you. Thank you very much, Dr. Sumit Singh, for a very comprehensive talk about diabetic neuropathy. We move on to the next speaker, Dr. Tushar Rege, who is the diabetic foot surgeon at Mumbai. Would like to know, very, very important, that management of foot, prevention of foot problem, which has drastically come down for the last 2 to 3 decades, thanks to the education of the patient and podiatrist, foot surgeon. The amputation rate, I'm sure in the last 10 years, what I had seen, gangrene we see has come down. Over to Dr. Tushar Rege to tell us about diabetic foot.
Thank you for moderating this session, and thanks to the WOCAD team for inviting me to be a panelist. The journey of diabetic foot, I would take you back 30 years, 35 years, when we were resident doctors, and a diabetic foot patient would be regaled to the veranda, maybe flies, maggots, smell of urusol, smell of iodine. And I would say that more than treatment, this patient was regaled to his fate. He would either land up with an amputation or some mutilating surgery, which would either not be a non-healing wound. And diabetic foot was never given an importance the way it deserved. Over a period of time, things started changing. And I think it began with change of perception. Diabetic foot from amputation started coming to a point where there had to be preservation of the foot or an attempt to prevent an amputation. And this became extremely important because in a diabetic foot, it just doesn't stop at an amputation. You amputate a foot and this patient either has an amputation of the other limb within 5 years. He has a cardiovascular event because now there is more strain on the heart because of a single limb. So, it was not just stopping the story with an amputation. It was continuation of the morbidity, continuation of the problems by doing an amputation or by performing an amputation. So the whole approach started changing over a period of time. And then over a period of time, sir, it has now become at least a subspecialty where there is a lot of stress given on preserving the foot, preventing amputation. And just going by the figures, when we are talking of almost 100,000 amputations just in India, and by amputations, I'm not talking of minor toe amputations, I'm talking of major amputations. So when I'm talking of major amputations, so when I'm talking of a major amputation, it means that it is either a forefoot amputation, below knee, or an above knee amputation. If there are 100,000 or 1 lakh amputations being conducted in India, it really needs a relook at foot care, at change of perception. And I'm sure over a period of time, is going to be a super specialty in diabetic foot surgeries. As Dr. Mohan said, that we really need to change curriculum. I do not remember reading anything about diabetic foot as an undergrad, whereas now as we learn more and more, I still feel we all diabetic foot surgeons are also into a learning phase, and so much to know, so much to learn about diabetic foot. Now, what exactly has changed? The first thing is a good understanding about the biomechanics of the foot today, with baropedograms, with good foot mapping, with mapping of neuropathy. One really knows which are the pressure points in a person's foot, and at a very early stage, corrective footwear, which will go a long way in preventing an ulcer just because of pressure on that neuropathic foot. So the first thing is understanding the biomechanics of the foot. The next thing I feel which has really changed is understanding wound management. There are so many different types of applications which have come in the market, and some of them are really excellent, considering the fact that there are wound management agents for desloughing, there are wound management agents for epithelialization, there are wound management agents for preventing further infection. Only thing, everything has to be judiciously used. Similarly, understanding the microbes which are affecting the foot. We have a wide range of antibiotics which are gram positive coverage, gram negative coverage. Wockhardt has come with innovative research oriented antibiotics. And I think all this is going to go a long way in preventing sepsis and controlling the foot infection per se. Coming from there, I feel the most important thing is now it's a multidisciplinary approach. From me being a solitary surgeon managing diabetic foot, no, I'm just a part of the team. I'm just a part of the team where there are multiple other people who are involved. And things which have really changed the outcome is number one, the understanding that diabetic foot is not just a microvascular disease, but a macrovascular disease. As a result of which, maybe 5 years or 10 years back, an ischemic foot would be just amputated because there is no blood flow or lessened blood flow. Today, with the presence of good interventional radiologists or vascular surgeons, sir, we have really been able to increase blood supply in the concerned angiosome to a significant extent, and what would have been a clear-cut amputation some time back can now be a foot preservation surgery. So that is the first thing I feel, that vascular intervention, a PAG-plasty or a bypass surgery has really made a lot of difference to increasing the vascularity of the foot. Number two, understanding the way a diabetic infection traverses along tissue planes. I feel myself, what would I have operated or debrided 5 years back, my own approach to my own patients has changed considerably. Now, in the first step itself, there is a significant radical debridement which has significantly decreased the number of debridements. Earlier it was maybe some conservative debridement, some part debrided, and then again finding that some tissue is necrosing, some pocket of pus which was missed. So I think over a period of time, that understanding of tissue plane and debriding maximally has again changed the whole approach to diabetic foot surgery. And the third thing is the presence of plastic or reconstructive surgeons, right from simple skin grafting to a major surgery whereby a free flap, that means a vascularized flap, which will cover a defect. So now when I operate, I really do not have to worry about the large raw area which I am leaving behind, because I have a good plastic surgeon, a team of plastic surgeons who will come to the rescue and cover whatever wound I leave behind. So with that, the amount of amputations, the number of amputations has really come down. But having said this, I feel, sir, we have, as you said, a decrease in amputations, but at the same time, that decrease in the number of amputations is not significant. We have a huge diabetic load in the country, huge problem of diabetic foot in the country, and a large number of them going to have some or the other surgical intervention would be necessary. And to that effect, I still feel that though we have the best of drugs, the best of knowledge, the best of plastic surgeons, the best of vascular intervention, but the final thing remains is an awareness. So whatever we do, unless the patient is made aware of his neuropathy, about his vascular problem, about his glycemic problems, we are not really going to have a control on diabetic foot. At the clinic, to begin with, sir, we had counselors, counselor who would sit with the patient, because a diabetic foot surgeon's OPD is like almost like a physician's OPD, a large number of patients, unlike surgical OPDs, which are small OPDs. Here it's like, because people keep coming recurrently with the problem, or if there's one problem, it just doesn't end. So we had a counselor at the clinic who would counsel patient, absolutely telling them about how to take care of the foot. We have now again come out with some innovation. We have something which is called diabetic pedicure. Now, diabetic pedicure, we have not started to attract patients. We have done it because anything which has to do with pedicure or something does attract a patient. And once that patient is in the chair, that same person who is doing pedicure, along the course of the pedicure, keeps telling this patient that, no, this is the way you're supposed to take care of the foot. This is how you clean the foot. This is how you cut the nail. This is how you do not injure the foot. This is the way you're supposed to wear footwear. So all I'm trying to tell you is that the whole approach to diabetic foot has changed. It has to change further. It has to be added more and more to the curriculum, probably been taken as a super specialty. And with these awareness programs, I think that is the point where we really will be able to really cut down on amputations. This concept of crosstalk is something wonderful, beautiful, because I think diabetes and its complications are all interlinked. A patient comes to me for a foot problem, but he has literally every problem that we have talked today. And therefore, unless and until all specialties are aware of what one is doing, number two, aware of the other person's style of functioning and treatment, we really wouldn't be able to give the best possible care to this patient. So with this small contribution, again, as I said, I must really thank you all for allowing me or inviting me to be a panelist over here. And the need of the hour is changing a person's approach, changing a person's perception to diabetic foot, and adding more and more things in the curriculum, with the final dream that diabetic foot surgery becomes a super specialty and not just a subspecialty. Thank you, sir.
Thank you very much, Dr. Tushar Rege, for an excellent talk. I agree, just like we started in the beginning. Even the diabetic foot is a multi-specialty. I remember 30 years back, first time I started in 90s, a diabetic foot clinic. And who should be part of it? Diabetic foot clinic was managed by endocrinologist. Then we had plastic surgeon, we had vascular surgeon, we had orthopedic surgeon, we had dietitian, we had a technician, everybody together. As Dr. Mohan started in the beginning, if he comes to one clinic, he has to pay 5 people, then it's cost. We said, no, there's only one file made and you pay only one consultation. So that the problems were less, patients are happy, come to the foot clinic, and vascular surgeon say, this is the case, I want to do it. Or orthopedic says, I would like to take X-ray, there's osteomyelitis. Endocrinologist will take care of diabetes. Podiatrist will say, no, he needs this foot care. So basically, I think even as you said, whether super specialty on, even the diabetic foot clinic should be multidisciplinary, where you need all these 6-7 people, including a psychiatrist also, where he has to counsel what is the problem before amputation. As I said, it has come down, but definitely still not to be done. Most of it is having clinics. We know in Bangalore, one of them had clinic in every district of Karnataka for 5 years, and then educating people, checking the foot. If every doctor, MBBS onwards, at least examines foot, that is a great thing. Many times patient has socks and shoes. Doctor, okay, it's all right. No need to take out your shoes. Lie down, I will examine. If you just look at foot every time the patient visit 3 months, 6 months, examine carefully the sole as well as the upper part. Look at the nails. Ask nurse to cut the nails properly. That will go a long way in preventing diabetic foot complications as well as amputation. There's a question for you. Dr. Tushar Rege. The question is, how should we manage hard callus like hardening in pressure areas of foot, which some patients claim to be painful? I would like to share one of my experiences where a surgeon excised the hard part in pressure area, but there is no overall improvement. This is from Dr. Vinod Kumar.
Sir, we must understand that a callus is formed as a result of constant pressure on a neuropathic foot. Now, the foot is neuropathic. The callus was there because of pressure. So, as a rule, the callus needs to be excised or removed. And why does it need to be removed is the whole concept has changed. Earlier, people used to feel a callus is like a helmet. It's protecting the foot over there. No longer. Now we feel a callus is like a small stone which is taped to the foot. Imagine a small spiky stone taped to the foot and a person keeps walking on that. This is exactly how a callus is going to act. So I remove the hard callus. If the patient keeps walking in the same way, the same factors are going. The patient's foot is neuropathic. That was his pressure area. So the callus is going to reform. So what he requires is a specialized footwear. And what is this specialized footwear? What we do is we just make a small hole in the insole. We have a thick insole of a simple thing, MCR, microcellular rubber. A hole is made and it is filled with silicone. So now when the patient walks, there is going to be pressure on that silicone. So that counter pressure is significantly reduced. The chances of callus forming is relatively less. I wouldn't say that the risk goes away, but the risk is relatively less, or the formation of callus takes a very long time. So it is important to offload. Offloading footwear is going to be the key for a recurrent callus.
Thank you, Dr. Tushar. There's one more question. I'm not very clear what they want. Pankaj Patwari has asked, want to keep foot moist, says healthy granulation tissue, and want to keep the foot dry, says educationist. Please guide which one is important diabetic. Maybe what he wants to know whether to use moisturizer to keep it moist so it does not happen, or keep it dry, otherwise go on putting water causing it. Which one you should follow?
Question is also not a bit clear, but I'll answer it in this way.
Whether to keep the foot moist with moisturizer or keep it dry, wash it and then dry that, or put the powder. This is what I think what he wants.
Yeah, a typical diabetic skin, because of AV shunts, the skin tends to become dry. A diabetic will never have a moist, nice skin. So we tell the patient that immediately after having bath, when the skin is moist, to use a moisturizer. Plain coconut oil, Vaseline, anything would be good. What is most important is that the interdigital spaces should be kept absolutely dry. Now, this is something important. Why? For two reasons. Foot is something which is not cleansed properly. Even the cleanest person is just going to maybe just dab his foot. What we need to do is clean in between the toes so that the foot remains dry. The second point is that because of the small muscular neuropathy, there is something called crowding of the toes. A diabetic foot is where all toes are not separate, they are all crowded, and therefore moisture tends to remain inside. So to prevent fungal infection, the most important thing is to keep the interdigital spaces absolutely dry. But the rest of the foot has to be moisturized. Moisturized means preferably with Vaseline, so that small itches, little itching or little scratches should not cause further infection.
I think you have hit the bullseye, made it very clear how the interdigital area has to be dry to prevent fungus, other area to moist to prevent others. There are 2-3 questions which I will take directed to me, before me to neurologist and the nephrologist. There are a lot of questions. I'll be very short and brief. Milind Satya has asked, the etiology of type 2 diabetes is insulin resistance. What are the drugs to reverse this? Remember, one of the best drugs to reverse, it's not actually reversal, reducing, I will say. Nothing will reverse. Everybody has insulin resistance from birth to death. It's a matter of degree. So pioglitazone is one drug which reduces insulin resistance of all the drugs. Remember that. Metformin is also another drug which is supposed to reduce the insulin resistance, but not as effective as pioglitazone, because metformin acts mostly by reducing the hepatic glucose output. Then again, most important thing is hyperglycemia itself increases insulin resistance, because once there is hyperglycemia, glucose toxicity, it acts on the peripheral tissue and increasing the insulin resistance. It acts on the beta cells, reducing the insulin release. So when you reduce the glucose toxicity, achieve euglycemia, that itself will reduce insulin resistance. Most important, weight loss if the patient is obese, and if you reduce weight, that will also reduce the insulin resistance. What is the role of frequency of diet during the whole day in insulin resistance? Please remember, the diet, most important is small frequent diet. If you give a large 2 meal, heavy lunch at 10 o'clock, heavy dinner at 9 o'clock in the evening, and a evening heavy snack, that's not good. Small frequent meals, because whenever you give a large meal, large carbohydrate meal, large fatty diet or anything, or total calorie, then the body cannot produce more insulin. So that is why every time hyperglycemia occurs. So small frequent meals, we advise type 2, breakfast, lunch and dinner, a small midday snack, a small evening snack and dinner. But it is not possible. It's very easy to tell this. Even for doctor to have 3 meal and 3 snacks, impossible. As far as possible, have small meal, frequent meals rather than going the too many meals. Then last question for me is, what is the role of statin in causing diabetes? Yes, definitely. A lot of studies have shown. That's why even FDA warning is that when you use statins, new onset of diabetes is more. So it's well proved that new onset of diabetes can be there starting. That's why the warning is there in that. So you have to, when you start patients on very high dose of statin, then only chances, not small dose. Or anybody starting statin, please look for diabetes every year. Check HbA1c if you can, or even fasting or postprandial, that is the one which you say. There's a question from Dr. Yadla Srinivas to our neurologist. So this is to Dr. Sumit Singh. Dear doctor, can we combine pregabalin and gabapentin in treating diabetic peripheral neuropathy? Right? Dr. Sumit, can you, is there? Dr. Sumit? Please unmute Dr. Sumit Singh.
Hello.
We can't hear you properly. Can we combine pregabalin and gabapentin? This is the question, Dr. Sumit.
Hello.
Can you hear us?
Yes, sir. We can hear you, Dr. Sumit. Now you are on mute.
Yeah.
Please remove the mute.
Please unmute now.
Dr. Sumit, can you please unmute?
Okay, now you talk. Fine. Please, Dr. Sumit Singh.
Hello.
Yeah, we can hear you. Please say.
Okay. Sorry. Yeah, this thing got mute, so I was not able to hear.
Yeah, the question is, can we combine pregabalin and gabalin in diabetic neuropathy?
Logically speaking, we can, because both have completely different mechanism of actions, but we usually do not, because the side effect becomes very, very problematic. So the drowsiness and all of the problems are not, but they're completely different mechanisms for action, so we can.
Correct. And by and large, what I see in my practice, neurologists are very fond of gabapentin and endocrinologists are very fond of pregabalin. As you said, it is your choice. There are a few questions to our nephrologist, Dr. Alan Almeida. These are questions directed to you, right? Just a minute. How do I go up?
There were 2 in the chat box which I answered already, typed out the answer.
No, that's what. Okay. So as I delete some of the questions, then I think it comes up there. I think these were, they were deleted, is it? Let me see in the other ones whether I can see. Yeah. Now, Dr. Alan Almeida, the question is, earlier metformin was contraindicated in CKD. Recently, in Journal of International Society of Peritoneal Dialysis, there was an article that metformin can be prescribed as per GFR report. Please guide us.
I have not come across that reference.
Okay.
But entire recommendation is that metformin should not be used with a GFR less than 30 ml. And in patients who had used it and who were on peritoneal dialysis, this of course was in the past, there have been episodes of lactic acidosis, which is the
And
one.
most important thing, by the time they reach 45, 30, none of them will be oral anti-diabetic. You take 15, 20 years to get diabetic kidney disease.
Yeah.
By that time, most of the patients are insulin. Insulin is the safest. All other drugs are not. Now, of course, SGLT2 can be used up to 45. There are studies up to 30 also. But how many patients by that stage, if you are diabetic 15 years, by 10 years are on insulin? So most often it does not make much help at all. There's one more question for you, Dr. Alan. Role of DAPA in non-diabetic CKD, and what is the extent mechanism of DAPA in diabetic nephropathy?
See, basically, the DAPA belongs to that SGLT2 inhibitors, and so they are basically acting in reducing the effect on the vasculature. There is a reduction in the GFR, which preserves the kidney, similar to not similar effect, but not similar action. Whereas with the ACE inhibitor ARB, you're reducing the efferent arteriolar constriction. Here we are increasing the afferent arteriolar vasodilatation, and that reduces the GFR and protects the kidney.
This is the last question. After that, we'll conclude. To Dr. Alan again, is there any contraindication to use of statin and antiplatelet drugs in end-stage renal disease? This is from Dr. Srinivas, Hyderabad.
Yeah, this also I had tackled on the question answers, which had typed out the answer. But the thing is this, that if your patient is on statins and antiplatelet agents before they have gone on dialysis, they continue it. There is no role, at least two studies, the 4D study and the SHARP study, do not show any role of statins to prevent cardiovascular disease in patients who are on dialysis. So you continue statins and antiplatelet agents through the dialysis.
Thank you very much. I would like to thank the organizers, and I would like to thank all the panelists, the cardiologist, Dr. J C Mohan, nephrologist, Dr. Alan Almeida, neurologist, Dr. Sumit Singh, and diabetic food specialist, Tushar Rege. I had an excellent time, really. I learned more from listening to other specialties rather than listening to diabetologists or endocrinologists. When I interact with stalwarts like you, the cardiologist, nephrologist, neurologist, food surgeon, I learn more rather than discussing 1 hour with endocrinologist. I am sure all the participants have benefited. Over to Dr. Rishi Jain for vote of thanks, and last 1 minute we have. Dr. Rishi Jain.
Thank you, sir. Thanks for such a nice moderation, and really a wealth of knowledge was there. I can see combined together all the 5 panelists, almost 150 years of clinical experience combined together. And that too, when it comes from across multiple specialties, I think all the audience have really got enlightened, and even for all of us, it was really, really very interesting. And the way it was made very lucid, the way it was presented without slides, and only the key takeaway messages was given to the audience. So I think the learning was much, much better, and all the takeaway points were really, really helpful. And the way audience has interacted, we are really helpful to all of them. So from bottom of our heart and on behalf of the organization, I would like to thank all the esteemed faculty members, Dr. Prasanna Kumar sir, Dr. J C Mohan sir, Dr. Alan Almeida sir, Dr. Tushar Rege sir, and Dr. Sumit Singh for really joining us today and making this panel really very interesting. And definitely we will connect again for such innovative ideas where cross-functional learning is definitely the way ahead in tackling diseases like diabetes and hypertension, where management requires a multidisciplinary approach. So thanks to all of you for joining us today, and thanks for joining to all the audiences as well.
Thank you. Bye. Good night, everybody. Thank you.
Thank you, sir. Good night.
Take care. Bye.
Thank you, sir. Thank you very much.
Thank you.
Thank you. Bye, Saho.
Bye.
Thank you, sir.
Thank you, sir.